Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to the National General Medical Oncology Summit. We're thrilled to be here this weekend. We'll be here all weekend with the Florida cancer specialist talking about taking care of patients and particularly what's new in terms of clinical research information. This is our agenda after this kickoff keynote session tonight on ER-positive metastatic breast cancer. Tomorrow we'll start out talking about Hodgkin, non-Hodgkin lymphoma, and we'll continue all the way to 5 o'clock, where we'll finish out talking about lung cancer. We'll pick up on Sunday morning bright and early, 7:30, talking about multiple myeloma, and we'll finish up at noon talking about pancreatic cancer. So for those of you who are here in the room, first of all, just to mention, here's the commercial support for the meeting. Also to mention that we will be talking about unapproved indications of agents, so please consult the prescribing information. We have an incredible faculty coming here this weekend, 31 investigators. And the theme of our work, and the theme has always been of our work, we pattern our programs after rounds. And the content that we're looking for is really a lot different than you see in other situations, in that we want to know from the investigators what we want to know. We're not asking them to tell us what they think we should know. We want to ask them. Okay, so the basis of everything, starting tomorrow, there'll be a Florida cancer specialist, general medical oncologist for all of our sessions, asking questions. So we put together, just to remind you, some videos just to remind you that that's our theme. Here's the first one from some of our breast investigators. All the videos you're going to see this weekend are from the last year.
So, very good question.
It's a good question.
I think that's a great question.
Well, that's the other good question.
Yeah, so that's a very good question.
Yeah, that's a great question.
Yeah, that's a fantastic question.
That's a good question.
Yeah, that's a good question.
It's a great question.
That's a good question.
So this will be our little inside thing this weekend that we're going to see if we can, make them say it. We want to ask the questions that's going to really challenge them. And here's where we're heading. We have we'll start out with 4 modules, and each one of those, the faculty will give a short presentation. And then for the 5th module, we have something a little bit different planned for this keynote session, something just to kick off the weekend to get us to think a little bit about patient care. We're going to be, as you know, tomorrow it's going to be all day, rock and roll. There are just so many things. But tonight, at the end of this, we're just going to take a deep breath and think a little bit about taking care of patients. We've always had interest, and we've done a number of programs over the years talking to clinicians who have cancer. We did a big roundtable with radiation oncologists, medical oncologists, and urologists who had prostate cancer. And we're kind of trying to ramp that up again this year. So tonight we actually are going to present 2 clinicians who have breast cancer. Susanna Fremel is a general medical oncologist in a small city, Bettendorf, Iowa. And she has presented cases to us. Ever since the pandemic, we've presented I think 3,500 cases from general oncologists, and she has been one of the oncologists. We mentioned on one of our programs that we were interested in talking to people, and she contacted me. So she's going to present a case for each one of these modules. She, interestingly, had a 8 millimeter primary tumor, node negative, ER positive, HER2 negative. She talked to her mentor from her training, who advised her to get a genomic assay. She had a low mammoprint, and she elected to take tamoxifen. She's been on it for 2 years and doing well. So she's going to be presenting cases. This is the other person that we're going to hear from. Dr. Cristina Ortega is a neuropsychologist at a pediatric for pediatrics at a hospital here in Broward County. Again, she was referred by her oncologist, and she actually had locally advanced. She deals with children, does neurologic assessments, etc. She actually had a locally advanced HER2-positive tumor that was diagnosed at the beginning of a pregnancy. She had a 2-year-old son at the time. She went through AC during pregnancy and then TCHP afterwards, followed by TDM1 and then neratinib, so a whole 2-year cycle. You'll hear from her about that. That's what we're going to talk about at the end, her observations as a patient, but also with her background. Here's a picture of her during her pregnancy, shortly after the pregnancy while she was getting the TCHP, and on the right, her current family. You know, something that you all see a lot and a lot of other people never see, and we're going to talk about that today. So we're going to start out talking about, we're going to talk about first-line therapy, particularly a choice of CDK inhibitor, and we're going to start out with a patient of Dr. Firmel. And so, Kevin, I'd like you to respond to this case. Interestingly, this is a woman who had infiltrating lobular cancer, Kevin. It's interesting, I was actually contacted. There's an advocacy group for lobular cancer, and they're like, where's the data for us? And everybody keeps telling us we just have ER-positive disease, but yet so that's a whole other story. Before I even get into that, any thoughts about that, Kevin?
Yeah, no, for sure. I mean, it's underrepresented in our clinical trials, and there are active, as you mentioned, there are advocacy groups. There are also groups that are looking to fund specifically research in invasive lobular cancer. But you're right, I think we lump them in with breast cancer, recognizing that invasive ductal is the majority of patients who are on the trials.
So to be continued, I'd like to do a program about it. I wish you guys could find some marker that would make it different, and then all of a sudden it'll be there. But anyhow, so she had this patient who had ER-positive or HER2 low disease, IHC1+, went on exemestane adjuvantly, and then got palbociclib. However, had problems with that and had to be switched to ribofulvestrant. And that's one of the things I want to get into and get your thoughts on, because Joyce is going to talk a lot about efficacy with CDK, but I also want to hear your thoughts about tolerability, et cetera. Here's Dr. Friemel's questions.
This is a 65-year-old woman who was initially diagnosed with the left breast infiltrating lobular carcinoma. She had a bone biopsy, which showed metastatic carcinoma consistent with breast primary. This time, the receptor showed ER 80%, PR was positive 65%, HER2 was IHC1+ low. She started treatment with palbociclib fulvestrant. She had trouble with abdominal low back pain with palbociclib, says symptoms resolved during week off treatment. We switched her therapy to ribociclib. She had complications with this too, decreased appetite, lower extremity cramping, diarrhea. We dose reduced to 400 milligrams twice daily, and she's tolerated it fairly well. So my questions for the experts would be, number one, if or when she develops disease progression, is there any value in repeating the liquid biopsy NGS testing, or would you just use the previous liquid biopsy information that shows the PIK3CA mutation to just go ahead and start alpelisib or some other medication? And would you consider a medicine other than alpelisib? I've had quite a lot of experience with alpelisib, and I've had one or two patients that had really bad issues with hyperglycemia, hospitalized, and they didn't want anything to do with it. But everybody else has tolerated it well. I have not had any experience yet with CAPI, but so that's one of my questions too. Would you use something other than alpelisib if she progresses, given the mutation?
So a lot of questions there, Joyce, and some of this I think I'll relate to later modules, but I just want to focus not only on the tolerability issues she faced, but also I didn't mention, but she mentioned that on diagnosis she had PIK3 mutation. And I was curious how often you see that. And you're going to present the data that just came out at San Antonio, this triplet with another PIK3 inavolisib. If you had a patient like this, if you could, would you want to treat her with a triplet? Any thoughts about the case and what you heard there, Joyce?
Yeah, she, it's interesting that she had GI tox. We don't see it that often, with the two together, but the dose reduction. So it sounds like it was really actually treatment related. So, the inavolisib, which I'll tell you about, is for people who hadn't seen a CDK4/6 inhibitor before. So, but once inavo is available, once it's available, we may want to use it in the second line. But in her case with the PIK3CA, well, first of all, the answer to your question, definitely get more ctDNA, because lobulars love to make HER2 mutations. They like to make HER2 activating mutations. Now, I wouldn't let that trump inhibition of PI3 kinase, though. I would go with inhibition of that pathway. One could do alpelisib, one could do capivasertib. I think either one with fulvestrant.
And we'll get into those decisions a lot tonight. I want to show you an interesting survey we did of investigators. But let's get back to this issue of kind of getting people through CDK. So, Erika, can you talk a little bit about some of the strategies you use, and particularly what I feel like I'm hearing more and more about is being aggressive about dose reduction. Can you comment on how you think about that?
Yeah, I mean, I think I agree with Joyce. The side effects that this particular lady had was not the typical side effects we see with CDK. But, I just had my first patient last week that almost had this anaphylaxis type reaction to letrozole with tongue swelling and stuff, the day after starting it. And I'd never seen that before anyway. So anybody can be intolerant of anything for any reason. I agree in terms of dose reductions. I think it's important to remember that the CDK4/6s are flat dosing, right? It's not based on somebody's body size. We don't know how people metabolize this. So sometimes people that have more side effects, it's really just a little bit too much for them. I think we're much more successful keeping people on therapy with the dose reduction and not stopping therapy and moving to something else. You could easily see in a case like this when somebody's having so much GI toxicity that they just say, I'm done, stop, right? And so, I really commend her for dose reducing because it sounds like the patient's tolerating much better now.
So I'm curious, Hope, when you bring up dose reduction and patients are doing well, do they push back on it a little bit? And do we have any evidence of whether or not it's safe from an anti-tumor perspective?
Yeah, I always tell people that the toxicity people have, except for the occasional patient who has totally wild toxicity that you can't explain. But for the majority of patients, it's like an in vivo pharmacogenomic test. As you heard, we don't have any idea how people metabolize the drugs and what the pharmacogenomics are of people who have more or less toxicity, but there's clearly got to be some inherent susceptibility. So the way the studies worked, you started at a dose and you reduced the dose with toxicity. So that seems to work really well because in all the CDK4/6 inhibitor studies, the efficacy was the same if you dose reduced, and the major issue was not dose reducing so that people discontinued drug.
Interesting. Okay, Joyce, so let's take a look at some data. I'll mention, too, an interesting side story. We're talking about this triplet, and I was actually, we had one of our meetings at San Antonio, we had Dr. Kaklamani there, and when in the faculty room, they were telling this story about how because the press release came out, I think, on the Tuesday of San Antonio. And they just jumped all over it, got to I hope you were involved. I don't know, probably half of you were involved. Mm-hmm. And they presented on Friday, which was like a world's record. They didn't want to wait until ASCO to see it. So hats off to San Antonio. Joyce, let's take a look at some data.
Okay, great. I'm going to talk about the role of CDK4/6 inhibitors in the management of HR-positive, HER2-negative metastatic breast cancer, which we know is a foundational treatment that we have for patients. Disclosures are there. I'll tell you first about this patient of mine, a young woman who was a psychiatrist in the hospital who had no family history of breast cancer, presented in 2010 now with a grade 2 T1CN0, ER 90%, PR 10%, HER2 negative, Ki67 20%. HER2 negative breast cancer. Germline testing showed a germline check 2 mutation. She had bilateral mastectomy. And she was treated with dose-dense AC, followed by weekly paclitaxel, then 2 years of leuprolide and tamoxifen, at which point she decided to take a 2-year hiatus from endocrine therapy to have her second child, which she promptly did, no problem. And then she decided to nurse her child for a year.
Can I just mention, and incidentally, we haven't started your talk yet, so your time is not so I should have mentioned that. But I was curious when I saw this because this looks like the positive strategy before the positive strategy was presented. And we're going to talk about that tomorrow. The whole, actually, Virginia's going to talk about tomorrow because they presented an update there. This idea of interrupting hormonal therapy But then this lady had metastatic disease, and with a small child, I guess.
Right, yeah. I had heartburn when she decided to nurse her child for a year, I'll be honest with you. I thought she should have had her child and got back on it, but, obviously women make that decision. And then it was actually good that the positive trial actually bolstered what she decided to do. But the thing about positive, we only have 4 years median follow-up, you know what I mean? So we need longer follow-up on positive. But anyway, it's super duper unfortunate. This is the only case I've had where the woman recurred having interrupted for pregnancy.
And she doesn't look like she's high risk either.
No. Germline check too, when you get those, you can have a lot of, genomic instability and subclones, et cetera. So she went back on leuprolide and tamoxifen in 2015, 2 years later, and then 2 years after that, she developed recurrent disease in her right pleura, presenting with a large effusion, which was cytologically positive, ER/PR positive, HER2 negative, Ki 67.15%, but that's all she had on PET. So she underwent BSO and started letrozole and palbociclib. But she had a rising, slowly rising CA2729 level, and we hung in there for 4 months, but then scans showed progressive disease, and the pleural biopsy at that time showed a ESR1 mutation. So we did a pleural biopsy. So I changed her to fulvestrant and abemaciclib, which she tolerated well at full dose, and she had a response to treatment on PET-CT for 13 months, at which time she progressed in the right pleural and right upper lobe.
And so, Erika, what would you want to know before you suggest what might be done?
Yeah, I mean, certainly this case was a while ago before we had as many options in terms of ESR1 mutations. I think what's reassuring about this case is that she's essentially on second-line endocrine therapy, and she still was progression-free for over a year. So that really kind of indicates to me that this patient is potentially somebody that could still get benefit from endocrine therapy.
Okay, Joyce, so what's the follow-up? What's the current situation?
Well, she lived 6.5 years with the metastatic disease. She died in September of 2023. So she must have had 15 regimens, basically. She really had everything, but she passed away in September. Yeah, very unfortunate.
All right, well, let's take a look at some data related to the issue of CDK inhibitors. One other thing, anything different about taking care of her as a psychiatrist? Did she have any observations, or was it just like another patient?
And her husband's a physician as well. It was interesting. Her husband took over all of the information. She did not want to be defined by breast cancer. She was an athlete, and she was a very fit athlete, and she didn't change anything. She got to be head of the department, and she did not want to be defined by breast cancer. She succeeded at that. But she let her husband get all the information.
Interesting. All right, let's take a look at some data.
So CDK4/6 inhibitors, as we all know, they're different one to another. And in the red box at the top, we see that ribo and abema are 4 to 5 times more selective towards CDK4 over CDK6. Palbo is about equipotent. But abemaciclib has a broader mechanism of action, particularly CDK2 and CDK9. So it's broader, and of course, we don't take a break. It's daily, right? BID daily. We don't have to take a break for myelosuppression because it doesn't inhibit CDK6 that much. So if we look at PFS in the first-line setting and look at the 3 studies in the middle, those are the pure first-line studies. Remarkably, we see absolutely identical PFS hazard ratios. And down the bottom, you can see that each of these increase median PFS from about 10 months to 14 months. So they look very similar, and these are all with AIs in the first-line setting. So let's look at the survival data. So ribo, now with very mature data, has achieved a statistically significant OS benefit in MONALEESA-2. It's about a 13-month improvement. You can see in the box it went from 51, I think it is, to 64 months over 5 years, and it's highly significant. The curves keep pulling apart. It's very, very nice data. Paloma-2, very strangely, did not have a survival advantage. The median survival in the control arm was 51 months, which was the same as in the MONALEESA-2, but the investigational arm did not have an improvement in survival. And you can see those down the bottom left that there's missing survival data in 13% of the palbo patients and 21% of the control patients. And of course, more patients crossed over to CDK4/6 on the control arm, 27% versus 12%. So a very puzzling and disappointing result. But on the top and on the bottom, what's in the red box is that for patients who had more endocrine therapy sensitive disease, they had a treatment-free interval off of their adjuvant endocrine therapy of at least a year. Those patients had a nice point estimate. They had a good result in Paloma 2 with regard to overall survival. The difference between the one on top is intent to treat, and the bottom is taking out the patients where the survival data were missing. So it kind of bolsters what I've thought for a long time about Palbo, which is that it is a good drug for patients who have endocrine therapy sensitive disease. Now, this is actually supported by the P-Reality X trial that Hope actually conducted. This was the Flatiron database, a very well done study, a very well done EMR, very careful statistical analyses, and it basically looked for patients getting first-line AI versus first-line AI plus palbociclib, and you can see the unadjusted analysis for survival on the left, and that's a significant improvement in survival. And for example, on the right, the statistical methodology to a balance between prognostic variables between arms that are not quite matched up. It's called the propensity score matching. You can also see this improvement in overall survival. So the real world data show that patients get a benefit from Palbo with regard to survival, but of course it's not randomized data. Now, Monarch 3, the updated data were presented at San Antonio by Matt Getz. And you remember Monarch 3 is the first-line abemaciclib trial. So the patients had finished up their adjuvant endocrine therapy if they weren't de novo metastatic, and they were off at least a year, and they could be de novo. And 483 patients were randomized to AI plus placebo or AI plus full-dose abema. Note the 493, that's a smaller number. The other two, Paloma 2 and Mona Lisa 2, had 666 patients. So it was about 1/3 smaller trial. It was a 2-to-1 randomization. So 2 patients got the abema and 1 just got endocrine therapy. And it's the endocrine therapy alone arm where most of your events are going to come from. And when you just have your 1/3 of the patients having AI alone, it took 8 years to get enough events. Now, a lot of things can happen in 8 years of treatment in the metastatic setting. But if we look at the PFS, this is the initial PFS. It was a 14-month improvement in median PFS with the abemaciclib. And now we're looking at the final survival data in the intent to treat. It was a co-primary endpoint with OS in patients with visceral disease. And you can see it's a 13-month improvement in survival in the intent to treat and a 15-month improvement in survival in the visceral disease patients, but it just missed statistical significance. I think the p-value is 0.06 for the intent to treat and 0.07 for visceral disease, and those were co-primary endpoints. So it just missed it, but the delta and the pulling apart of the curves is just what we had seen before, and I'll show you the interim analysis data. The forest plot shows that all of the subgroups benefit. We did have an update on median PFS, and the median PFS data are even better now than they were initially, and so very robust. And then we also see chemotherapy-free interval was very substantially, of course, in favor of the abemaciclib. I think it was a 16-month improvement in being able to avoid and postpone the initiation of chemotherapy. The PFS in subgroups in Monarch 3 is interesting. These data inform my practice. I use the first-line abemaciclib for the severe case, the patients who I do not think are going to benefit from endocrine therapy alone. That's where I use abemaciclib, and it's kind of borne out here, the PR-negative disease, the liver metastasis, the short treatment-free interval, and the higher grade. You can see patients do equally well with those severe, endocrine therapy resistant characteristics, and so that's where I use the abemaciclib, because those data are meaningful to me. Now, if we compare Mona Lisa 2 on the right, so that's AI plus minus ribo, and Monarch 3 on the left, the middle panel is the interim analysis at 70 months median follow-up, and then Monarch 3, the final overall survival, 96 months on the left. And we can see, if you look the second from the bottom, we can see that the differences in survival, they're very similar in terms of the delta on survival. But the differences here are in the number of patients. Now look at the middle panel. You see the hazard ratio there, 0.75. And you see the p-value, 0.03, okay? That would have been significant were it not for the fact that there was a co-primary endpoint of the visceral disease, and so that 0.03 did not meet the pre-specified p-value for a co-primary endpoint. So then we got the final survival, 0.8 on the hazard ratio and the 0.006. But to me, these data didn't change anything that I thought about abemaciclib. To me, these data show the same delta on survival that they showed in the interim and that we show in Mona Lisa 2. Now, of course, there's differences in toxicities. We obviously bring into account the toxicities all the time for our patients. Neutropenia, diarrhea with abema, QTc prolongation in a very tiny minority of patients with ribociclib, and then the AST elevation. Just had a patient with autoimmune hepatitis, so I could not recommend ribociclib for her. That would have been my first choice for her in the first line, but I couldn't because of her autoimmune hepatitis. As we just mentioned, both in Monarch 2, which is the second line with fulvestrant abema, and Monarch 3, the first line AI plus abema, if you reduce the dose from 150 down to 100 BID or even down to 50 BID, there's no diminution at all in PFS benefit. So that's very, very clear. So in NAVO 120, that Hope gave a fabulous discussion of at San Antonio, now this is first-line metastatic, but it's for patients with a PIK3CA mutation. And they either occurred on adjuvant endocrine therapy or within a year of finishing their adjuvant endocrine therapy. So a severe group of patients, and they were randomized to palbo fulvestrant with or without the oral inhibitor of PIK3CA, inavolisib. So they had to have centrally confirmed PI3 kinase mutation. And look at this beautiful improvement in PFS. Look at the median PFS with palbo fulvestrant. It was only 7.3 months short. And this is first line, but it doubled up to 15 months. And also survival is looking it's not significant yet, but it's, it is, I think it's not yet. No, it's down the bottom. It's not significant yet, but it's almost significant. But it does have hyperglycemia. It's similar to alpelisib, but not as much because the patients had to have very strict glucose control to get on the study. I think it was 5.8% or less on the hemoglobin A1C. It does have some rash. It does have some diarrhea, as we see with alpelisib, but less. Another question in the CDK world, of course, and this is brought to us by Kevin, is what about CDK after CDK? And Kevin showed us that when patients essentially had AI palbo first line and were randomized to fulvestrant plus minus ribo second line, that you got a significant improvement in PFS. So changing the endocrine therapy and changing the CDK4/6 inhibitor. If you just change the endocrine therapy, so if it's AI palbo first line and it's randomized to fulvestrant with or without palbo, so palbo after palbo, there are two studies. This is one that shows no benefit. So you have to change both the endocrine therapy and the CDK4/6, but we're waiting for the post-Monarch and the EMBER-3. These are phase 3 studies looking at abema after progression on first-line palbo or ribo. So there's going to be phase 3 data here to guide us.
All right, that was awesome. We had a question that came in from the people on Zoom, from somebody on Zoom. Rosanna, hey Rosanna, how you doing? Wants to know, do you pick capi or alpelisib? We're about to get into that, Rosanna, so I want to show you something. This is a CME program we recently did with Dr. Kamal Javari from Memorial. And so first of all, we're going to show you the results of a survey we did of 20 investigators for this program. But first, I just want to let you listen to and more watch Dr. Javari because to me, one of the things you miss, people love our audio programs, but sometimes you miss a little bit. And Kamal talks with her hands, but to me, I'd rather see somebody do that than see a big diagram of mechanisms. Here's what I mean.
If you think about ER is downstream of CDK4/6. And if I were to just think about a linear tree, you think about PI3K, AKT right up top. You do see CDK4/6 here, and then you have ER. And I think it's a complex cascade, right? They're all kind of, when you think about CDK4/6, these are kinases that are activated in ER-positive tumors.
So, Hope, we did a program I was recording a program on myelofibrosis a couple days ago, and there was this mechanism thing with literally 100 different, things on it. I'm like, oh, I don't get that, but anyhow. All right, so here's what I want to show you, which is a simple survey that I would like to submit to San Antonio. We've done things like this before. I think a lot of you actually were on this survey. Joyce was. So choice of CDK in general, when we ask people premenopausal as well as postmenopausal, is Ribo. Hope, I don't know, after your real-world experience with Palbo, are you still using Ribo? Are you using Ribo, or what are you doing first line?
I think we all switched over to using primarily Ribo in our premenopausal patients first, and then in our postmenopausal patients, really because you didn't get the diarrhea of Abema, which frightens people. Somebody just sent me a message saying, if I start at 100 milligrams BID, when will I have a normal life again? I was like, really? But it's actually pretty good, She doesn't believe me yet. But and she's part of this big advocacy population, so I definitely think that is the word on the street. For Ribo, the main issues we run into is the cytopenias and liver enzyme elevations, which was the most common reason for discontinuation. So I still find that Palbo has a lot of advantages. We use it in older patients. We're just starting an 82-year-old on a CDK4/6 inhibitor. I choose Palbo then, and I'm guessing most of us would. And in somebody who has toxicity, we back up.
So, Erika, why don't you take the next couple? So one question, we're seeing more and more people give CDK in the adjuvant setting. What about in patients who recur? What period of time? We've, of course, had this issue in oncology a long time, even with chemo. Looks like people want to see a year or more. Any thoughts? If you see 3, 4, or 5 years, how much better is that?
Yeah, I agree. I think if you have somebody that relapses while on it or, in close proximity, you're probably thinking that disease is really resistant and you're not going to get much benefit. I think the interesting question is since really right now we're using abemaciclib in the adjuvant setting, if we were to switch in the metastatic setting, we're kind of talking Palbo or Ribo. And we even have less data of those ADCs after Abema. So, we don't have a whole lot of data there.
Although we have, Maintain, that was Ribo after Palbo, but that was metastatic.
That was metastatic.
Right.
But yeah. In post-Monarch, if I may.
Sure.
There was the allowance to have received a CDK4/6 inhibitor in the adjuvant setting and then progress. But given the timeline of when that study was conducted, it's going to represent a very small population.
Right. Okay, so here's what I'm excited about. And little things make me excited, particularly if they clarify things. So here's one situation. There's several we asked these 20 investigators about. Very common situation, postmenopausal woman who has a minimally symptomatic metastatic disease after 2 years on adjuvant AI. She gets CDK inhibitor with fulvestrant, responds, but then has disease progression in 18 months. So the question is, what do you do next in terms of second-line therapy? And my answer is, first of all, you got to get these 3 biomarkers, right? This is like the new ER and HER2. You cannot make the decision without this. And so what we want to submit is a bunch of cases with different biomarkers. Very simple, but it's not that simple. So let me just throw a few of these. And Kevin, why don't you take the next couple? So, all right, ESR1, SERD, elacestrant's the one available. That's great. ESR1 and PIK3, you're about to see that patient presented to you. And you see a consensus here, just kidding, split between elacestrant and Cappy. And Rosanna from the chat room, that's what she's asking about. Okay, here we go more. Now all 3, same thing. So first of all, at this point, Kevin, any thoughts?
Yeah, this is the situation I think that we're in now. When we give elacestrant, we don't have data about giving that in combination with a targeted therapy like a PI3K or AKT inhibitor. We won't forever be in this circumstance, but this is where we are right now. And so for me, it slightly depends on what's going on. And what I mean by that is if I have a patient, if this particular patient remains having bone disease only, if that's the progression that we're seeing, she did demonstrate that she was on her fulvestrant and CDK4/6 inhibitor for 18 months prior, and we saw with Virginia's data that if you were on that for about 12 months or greater, that you benefited from elacestrant. I think that's reasonable. If I had a patient that, if this patient had significant liver disease and I felt like I needed a little bit more bang for my buck in response, that's when I would do capi plus fulvestrant.
Keep in mind, these people have to take care of bladder cancer, CLL, myeloma.
Yes.
So, okay, of course, you have all kinds of things that you're thinking about, but, let's just get to first base here.
Yes.
Again, if you buy into, I don't know if the audience is already on board with this sort of triple biomarker, so everything negative, and you have, exemestane, everolimus, or maybe even starting chemo. This is a really interesting and I think relevant, and Joyce, maybe you can comment. This is really Rosanna's question, which is why are people using capi here? The thing about capi is it's given 4 days on, 3 days off, which I think is very interesting and maybe has a big effect on tolerability. I don't know if alpelisib was ever looked at that way, but Joyce, in general, you're a very creative thinker. What do you think? This is a sort of simple situation. First case, only pick 3. What are you thinking?
With an ESR1 and PIK3CA, we saw data at San Antonio, subset analysis of EMERALD, and you still get benefit. It is a little bigger if you're wild type for PIK3CA and ESR1. This is people that got at least 12 months on
But this
CDK.
is ESR1 negative.
Oh, this is ESR1 negative. Oh, for PIK3CA, I think many of us are really going with capivasertib now, and it's also, it liberalizes the hemoglobin A1C up to 8.5%. And you're right, Neil, with the BID, 400 BID, 4 on and 3 days off, it really ameliorates the toxicity.
Do you see differences in their glucose or how they feel when they're off HOPE?
It's an interesting thing. The glucose part of it tends to be more conserved regardless of whether they're off or on. So they have very strict, these patients are all on trials when they getting capivasertib. So 4 days on, 3 days off. If you have a slight increase in glucose, we use metformin, it works fine. I have yet to have a patient who had big glucose issues taking doublet therapy with capivasertib. But, you have to manage the diarrhea and the rash because that comes, some people get it on their days off, some people get it on their days on. Dose reduction works really well. And most people, I have somebody who's been on, I think, for Capitello 291 for almost 3 years. And so she's doing fine. She thinks it's really good not to be constipated, actually. She was telling me last week. So she does fine. But the one thing I do want to point out is this patient that you presented had fulvestrant and progressed. And nobody was on the CAPI study who had fulvestrant and progressed. And similarly, the elacestrant data is pretty good, and we like it, but they looked at the patients who hadn't had fulvestrant, right? So they were comparing fulvestrant to elacestrant as part of the subset analysis. So, I think one of the important things for us is to get those markers when somebody progresses on the first-line therapy, because we might change a little bit of what we did. Now, in this case, the patient had a really long response to abema, so it's kind of hard to know whether that was, what the reason for that was.
Kevin, you had a thought, and also I'm curious whether there are any situations where you skip second-line hormonal therapy. They recur on, an adjuvant AI, for example, within a few months or so.
Yes. So the one point that I was going to make was in the original development with CAPI, there were some smaller phase 1 studies, one that was run out of MSK and then another one that was through the NCI match. And so for patients who had AKT1 mutations, there were some patients who had tumors that had progressed on fulvestrant, and then they were allowed to continue the fulvestrant and add in the CAPI, and they saw some responses. We don't know about for PIK3CA mutations, but with AKT1 mutations that has been seen. And then, there are some patients, if they are, progressing on their adjuvant aromatase inhibitor, and they, really have significant rapid disease progression, then sometimes one may think about giving other systemic therapy like chemo or maybe an ADC. But I will also say, we have data from the Right Choice study, which compared doublet chemotherapy versus fulvestrant plus CDK4/6. And those patients who had quote unquote symptomatic disease or visceral disease really benefited more from that, doublet fulvestrant or hormonal therapy ribo compared to doublet chemo.
That's a great point. Joyce, do you agree in general? Although you can see some exceptions here when we ask people to compare the 3 most studied SERDs. in terms of efficacy. Most people think they're about the same. Well, a few people think Cami is more efficacious. And then tolerability, again, majority say you can't distinguish tolerability. Few people say elacestrant is more tolerable. Joyce, looking at the data in your own clinical practice, any thoughts?
From what I've seen, we should hear from Erika, who's given these a ton. I would say, the data, looking at the data, they look approximately the same in terms of efficacy. They've been looked at in different lines of therapy, so it's apples to oranges. But some of them have a little bit more diarrhea. I think camizestrant has a little bit more diarrhea, and imlunestrant has some diarrhea too, but elacestrant doesn't. But Erika's had a lot more experience.
Yeah, I agree. I think in general they're similar. Exactly, to Joyce's point, I think there are certain of them that have a little bit more GI toxicity. Some of the ones that weren't on the screen, I think, were the ones that were worse in terms of GI toxicity. And then, there are these little one-offs, bradycardia or the visual effect with camizestrant. In general, I think we are much more concerned about that than we should be. Patients don't tend to be concerned about that. It's just lower, resting heart rate. If you walk them around the nurse's station or they go on a hike, their heart rate goes up. Nobody's passing out or anything like that. And the photopsia is kind of a fancy word, but what it really means is I liken it to the movie theater phenomenon. So reading, driving at night, vision, all of that's fine. It's when you flip the lights on first thing in the morning and your rods have to adjust in a change of ambient light that you get a little bit of blurring at the edge of the vision for about a minute or so. Same as when you turn the nightstand off at night and close your eyes, you see that on the edges, and it's just the rods acclimating. You stop the drug, it goes away. So it's not affecting their vision. It's really just an ion channel phenomenon.
Onco-ophthalmology. We did an entire CME program with ophthalmology. This is a great slide I pulled from San Antonio, but just check it out if you get a chance. It gets into differences between these various agents, including everolimus, which I thought was interesting. We'll talk about this later, but just to complete the survey, HER2 low, hormone receptor positive. In general, people are thinking about TDXD first. We've heard this story for a while. They're thinking about SASE second. But just to come back to you, Hope, and we'll talk about this later, but as long as we're bringing it right now, particularly in terms of ER positive, you still do TDXD if the patient has low-grade disease or not symptomatic?
No, I think this is chemo, clearly, and so we want to balance the toxicity for patients. I think in ER-negative disease, we don't have something else to do, right? So we're going to be giving them chemotherapy. I still generally give sacituzumab first.
In ER positive?
In ER positive and HER2 low, we give TDXD first. So, I think that when you're dealing with we always have to deal with the individual patient, but now I have a lot of patients where they've progressed. I was thinking about some of these cases, and we biopsy and their ER is 0, and they're 8 years on their adjuvant AI, they relapse in liver and lung and everything we biopsy, it's all ER 0 or ER 10%. So I've seen a lot more ER loss now since we've been treating patients. So those kind of patients that had ER positive disease, they still have some biology of it. I tend to give more TDXD even though they're ER negative, with variable results, I have to say. You're balancing hair loss, frequency of being seen, nausea versus more cytopenias, things like that.
All right. Well, Erika, you have a great talk on SERDs, but let's get to one case. This is a patient who has metastatic disease, both PIK3 and ESR1. You saw how the panel reacted to that. Kevin, maybe you can respond to this case. Here's Dr. Freemill.
5 years of adjuvant endocrine therapy with tamoxifen. 4 years later, she developed progressive low back pain, diagnosed with metastatic disease to lumbar spine. No other disease on imaging. Poor biopsy, ER positive, 95% PR negative. HER2 was IHC 1+. So I guess one of my first questions for the experts is if she develops progressive disease on elacestrant, is there any role for CAPI? And then she was told after being on a Facebook group that there's a delayed time to effect with elacestrant. She says like 4 months. So I was wondering if there are any comments about, time to develop a symptom response on this medicine.
Any questions about what might come next?
She's not had any chemotherapy. So if she does have disease progression, to put her on capecitabine. And then if she progresses on that, then since she's HER2 IHC 1+ low, probably TDXD, unless data comes out after that maybe SASE is better than that.
So again, Kevin, the double mutant patient ESR1 and PIK3 was already mentioned, data from San Antonio showing that elacestrant seems to be effective in patients like this. How do you think through? This patient ended up getting it sequentially. Would you consider the triplet if you could?
I don't know that I would give the triplet now. The population that Joyce was talking about, where we were giving triplet therapy, that was really, frontline progressors from the adjuvant setting, who progressed on their adjuvant therapy within a year of that.
And not only, you said they had a low BMI also, in addition to
there were other requirements
or no?
also. Yes.
No, not
And actually,
BMI.
yeah, I mean, you had to have, your hemoglobin A1C needed to be within a certain level. And actually, that study took some time to really accrue because it was such a narrow population. But I think for this particular patient, if I have a patient who had a tumor that progressed on elacestrant, still has a PIK3CA mutation, I think it's reasonable to think about fulvestrant plus capivasertib for this.
Do you lose PIK3?
No. In general, PIK3CA mutations are seen early. We see them in the primary. And there have been studies that have looked at, from the CDK4/6 inhibitors trials before and after. And for some, there was a slight increased rate of PIK3CA mutations. We don't see them go down, but usually we see these early on, even in the primary tumors.
Interesting. All right, Erika, let's take a look at some data.
Okay, so this is a case, and I think one of the things I'm hearing a lot is, well, after endocrine therapy in the resistant setting, people just don't get much benefit to these drugs. We're talking about 4 months, so shouldn't I just move to chemo because none of these drugs really work? And so this was just a case of a lady who, interestingly, actually had this HER2 positivity initially. Ended up relapsing, and she was on fulvestrant with trastuzumab, letrozole ribo, trastuzumab, and then kind of lost that HER2 back in 2019. She was on an oral SERD, then she was on an oral SERCA, and you see she got about 10 months on SERD, 6 months on SERCA. She was on a CAT6 for about 5 months, and at that point we did move on to capecitabine, but she did horrible on capecitabine. She had a really bad GI toxicity, actually ended up in the hospital, and then she progressed. You would have thought she would have been a responder, and she wasn't. And so we actually went back to endocrine therapy with a PROTAC at that point. It was in combination with palbociclib, and she got another 9 months benefit. So I show you this case just because people can continue to get benefit from endocrine therapy. So I think our challenge as clinicians is really picking who needs to move on to chemotherapy and who doesn't. So I'm going to go through some of the oral SERD data here, and we'll start with a little bit about biomarkers. I completely echo your statement that biomarkers seems kind of overwhelming at this point, and there's so many across so many diseases, but biomarkers aren't new. ER and HER2 was a biomarker, and we've been using that for quite some time. So really what we care about in breast cancer predominantly is ESR1 mutations, PI3, and then now also AKT-PTEN, and then also to remember that our ER-positive patients can also have BRCA alterations, so PARP inhibitors can definitely play in here as well. And so, obviously we've gone through those 4, but for patients that kind of become endocrine resistant and later line therapy, certainly HER2 low with the antibody-drug conjugates matters, and I think we're going to get into a little bit of that later. And then also some of these markers for immunotherapy, as well as the needle in the haystack that I have still never found myself, which is an NTRK fusion, but I'm holding out for that one day. Mm-hmm. So this is really, I think, the treatment algorithm. In the first line setting, pretty uniformly, we're using a CDK4/6 inhibitor. Most of these patients, it's probably with AI, but the caveat that some patients are receiving fulvestrant if they've relapsed, on or close to AI. And then in second and third line, this is where it becomes a little bit biomarker driven. We're looking for PI3 alterations, AKT. We're certainly looking for PTEN as well, the PARP inhibitors for BRCA alterations, and then now elacestrant linked to ESR1 mutation as the benefit there was a little bit higher. Once patients aren't endocrine sensitive anymore, and I really want to emphasize that caveat because if people are still getting good benefit to endocrine therapy, I don't want to move on to antibody-drug conjugates. That's a chemotherapy, and I'm really going to exhaust my endocrine therapy and be confident that the patient's not responding there before I move on to chemo or chemo alternatives. So let's go through some of the SERD data. This was the first one we saw. This was Emerald with elacestrant. This was a pretty clean study. It was randomized elacestrant or investigator's choice of fulvestrant, anastrozole, letrozole, or exemestane. And the thing to remember here is that everyone had already seen a CDK4/6 inhibitor, so a homogeneous population. These patients were pretty heavily pretreated. Just in terms of endocrine therapies, about 45% had seen 2 lines. About half had an ESR1 mutation, but chemo was actually pretty rare, only at about 20%. And I know this is tiny, but this is progression-free survival, and you can see that this was statistically significant, but it was only a 1-month benefit. And then if we selected for those patients that had ESR1 mutations, that spread or that delta went up to 2 months. And so that was the indication that this was approved for. Over on the right, it gets a little bit complicated, but essentially on the top, we're looking at duration of prior CDK. And then on the bottom, we're looking at duration of prior CDK if you have an ESR1 mutation. And so if you look at these at least 12 months or at least 18 months on a CDK, you really see here a clear spread with elacestrant compared to other endocrine therapies, really 8.6 months in those bottom 2 right graphs compared to just about 2 months with standard endocrine therapy. So obviously elacestrant is approved for those patients that have ESR1 mutations. The rest of these are not approved yet. Camizestrant is the other one that we do have randomized data for right now. This was SERENA-2, and they actually looked at 2 different doses of camizestrant, 75 milligrams as well as 150 milligrams. This was presented not this past San Antonio, but the year before. And they certainly did allow CDK, but as you can see in the bottom right, only about half of patients had CDK, and this was based on countries that this trial was enrolling and access to the CDK. You see a little bit less ESR1 mutations, about a third of patients, and you see that about half of patients had AI for metastatic disease. Now, whether we look at the 75 milligram dose or the 150 milligram dose, a clear winner over fulvestrant. So you see 3.7 months with fulvestrant and a little over 7 months with the camizestrant. Kind of ask the question of, well, wait a minute, I thought fulvestrant was only supposed to give us about 2 months. Remember that not all of these patients had seen CDK, so it's a little bit of a mixed population, and that's why we're seeing fulvestrant perform a little bit better. And then last but not least is imlunestrant. We don't have randomized data with imlunestrant yet, but certainly imlunestrant is being looked at in a variety of combinations. You see over on the right with the abemaciclib, CDK, everolimus, or alpelisib. And these are the responses. And I know this is a little bit of a busy slide, but you can see that progression-free survival among all comers that were receiving imlunestrant was about 4.3 months. But if we look at specifically those patients in the second-line setting, so less heavily pretreated and had seen CDK, you have about 6 months benefit. And then you can see over on the right side of this colorful graph, you see some of these combinations with everolimus or alpelisib, and you get the gestalt that when you add with combination, you're getting a little bit better responses, which is, I think, in general, what we're seeing with a lot of endocrine therapies, just with endocrine resistance, that some of our combinations are performing a bit better. So this was the updated efficacy. You can also see with these little arrows the patients that are ongoing. So the abemaciclib arm in particular, it looks like there's still quite a few patients ongoing. And then just to kind of talk a little bit about standard endocrine therapy versus the oral SERDs. So I think we are all very familiar with aromatase inhibitors. In general, most patients tolerate this okay, but it certainly can have a lot of side effects in terms of arthralgia, vaginal dryness, and sexual side effects. Certainly osteoporosis and hot flashes. And then fulvestrant, really the biggest complaint really is the hip pain, where we're having to get 2 injections every 4 weeks. In terms of the oral SERDs, I think the side effect really across the class is a little bit of GI toxicity. There's certainly some compounds that I think have a little bit more of that than others, although it's hard to compare apples to apples because a lot of these were phase 1 population and we can just see a lot of GI toxicity there. And then we've already touched on the bradycardia and the photopsia. So in summary, I think that oral SERDs do potentially offer some advantages over conventional endocrine therapy, certainly more bioavailable. They do appear to have better single agent efficacy, but certainly these drugs can be combined with things that we typically combine for in ER positive breast cancer, certainly CDKs, AKT, PI3. And data from randomized trials have demonstrated their activity in combination with CDK as well as in the post-CDK setting. There are a variety of trials ongoing here. Second line post-CDK, first line in combination with CDK, adjuvant up front, adjuvant switch strategy based on ESR1, or adjuvant switch strategy just based on the old TAM to AI data where at a certain interval for 3 to 5 years, we switch after somebody has received endocrine therapy. So we're gonna see a lot more activity and information coming in about these. And so this really just highlights these clinical trials that are ongoing. On the left, really single agent, and you can see quite a few in even the early stage settings enrolling right now. And over on the right, we're looking at a variety of combinations, not just CDK and PI3 mTOR, but other pathways as well.
So a couple follow-up questions. Erika, in the video, Dr. Friemel mentioned that she heard from a patient, advocacy, Facebook, et cetera, that oral SERD specific L-estrogen take a while to work. Mm-hmm. Is that true, or any thoughts?
I haven't heard that. I mean, I think, one thing that's true is we don't tend to see robust responses to endocrine therapies. This isn't something where you're going to see typically a 40% PR. That's the reason we really look at progression-free survival and clinical benefit rate here, is because these aren't really fast-growing tumors. And so when we start a drug, they don't tend to melt away like a triple-negative breast cancer can. But I don't think that there's this delayed response like you might think about with immune therapy or anything else.
So Joyce, interesting question from Jaspreet here in the audience, wants to know, would you wait for radiologic progression to start a SERD versus starting when you see ESR1 appear on liquid biopsy? And I would add to that, are there trials looking at that kind of strategy?
Yes, the SERENA-6 trial is ongoing, and I predict it's going to change how we treat patients, because we saw in this upfront trial called PATA-1, patients were on AI plus Palbo, and they were monitoring for ESR1 mutations. I think it was every 3 months. And when they found an ESR1 mutation, patients were randomized to continue same AI plus Palbo or switch to fulvestrant plus Palbo. And the Palbo, is effective against some of the ESR1 mutations, and the median PFS was improved by about 9 months or so. We don't have survival data. Some would say, we shouldn't do this until we have survival, but I put myself in a patient's standpoint. If I've got AI plus CDK and I'm enjoying a fabulous quality of life and a good response, I'd rather know when that ESR1 comes up, and I'd rather switch to a SERD at that point. And that's what the SERENA-6 is doing with camizestrant.
So we're going to move on now, and Kevin is going to review. We have lots of questions about management tolerability issues with these agents. We'll get into that in a second. He's going to talk about agents going after the PI3 AKT mTOR pathway. But first, another case from Dr. Friemel. And before I talk about the case, Hope, just curious, this is a woman who presents with metastatic ER-positive, HER2-low breast cancer. We were talking about endocrine-sensitive situations. How would you compare somebody who presents with metastatic disease, ER-positive, somebody who we've been talking about it, either had adjuvant therapy in the past and is off it, or on adjuvant therapy?
So this is a patient
Presents with METs.
who had adjuvant therapy or is off of it.
No, she presented with METs.
Right, the de novo metastatic. Oh, compared to, I got it,
right.
compared to those. I think that, the de novo patients, it's kind of funny. I mean, We would like to believe that because they haven't gotten treatment that they're going to do much better. But of course, there is the biology that led them to have metastatic disease. So if it's somebody with an ignored cancer, yes. But there's also this group of patients that just have biologically more heterogeneous disease that metastasizes when it's a small tumor, sometimes even node negative, rather shocking to all of us when we're evaluating these patients. And I think that in that situation where you had de novo metastatic disease, our treatment is relatively similar in the first line setting with an AI and CDK4/6 inhibitor. We may be changing a little bit with these triplets, but not quite yet. And then in the second line setting, in a patient like this, you would want to target the PIK3CA mutation. If they have an ESR1 RUNX1 fusion, I would email everybody I knew to know whether or not that had the same impact on resistance. Because, there are resistance mutations in ESR1 that mean that fulvestrant doesn't work as well. But we also know from looking at NTREX, because, we're all looking for NTREX fusion genes, right? And all you see are like this panoply of mutations of NTREX that are not the fusion genes. So in this case, I don't know if that fusion correlates to the same degree.
I got a great idea. Why don't you send an email down to the end of the line there to Dr. O'Shaughnessy? Yeah. But before you answer, Joyce, let's hear Dr. Friemel, and you can answer Hope and Dr. Friemel.
58-year-old postmenopausal woman who developed some left hip pain, was diagnosed with a pathologic fracture of the left femur in October of 2020. Imaging showed numerous lytic bone lesions and then some abnormalities, possible metastatic disease in the liver. She underwent surgery to the left femur, and she was started on palbociclib letrozole. And she has basically near complete resolution of metabolic activity, the right breast, the primary, and nothing on exam, nothing that's noticeable. Her liver metastatic disease and the upper abdominal lymphadenopathy is no longer appreciated. So she's had a great response. The diffuse osseous metastatic disease is slowly improved. So now she's been on this regimen for over 3 years. She has no bone pain. The NGS showed the PIK3CA mutation, but also an ESR1 RUNX1 fusion. So my questions are to the experts. One, she has future evidence of progressive disease on imaging. Therapy options include, I guess, alpelisib or capi with fulvestrant. But then do you have to think about using fulvestrant? The ESR1 RUNX1 fusion, does that have anything to do with the ESR1 mutation? My second question was, again, she's been on this current therapy now with stable disease after a very good disease response for over 3 years. If she does develop progressive disease, would the duration that she's been on the AI and the CDK4/6 inhibitor, would that influence your choice of the next line treatment at progression versus if she had progression after 1 year of therapy, for example?
I'll add one. Can you predict who's going to have a 3-year response like this? How about the questions about this RUNX fusion? Is that like ESR1, Joyce?
So the most common
you just looked it up on your phone?
Yeah, well, no. I want to get there's a very common one that I see actually a lot, and it's the ESR1 CCDC170. That's the most common one, okay?
That's just a regular mutation, not a fusion.
It's a fusion. It's a fusion, and you get the loss of the ligand binding domain. And so I asked Stemline Menarini, what do you know about it? And they don't have any clinical data because they weren't eligible for the study. But I looked at the preclinical data. The SERDs don't work because you've lost the ligand binding domain. And so I don't know about the RUNX1, but the most common one is CCDC170. And at least the preclinical data would suggest it doesn't work because the elacestrant binds at the ligand binding domain.
Awesome. All right, Kevin, let's take a look at some data.
All right. So I actually had 2 cases that I had debated, and I went with the safer of the cases, and I'm happy to discuss the other case.
We might have to ask you about that.
Which is a patient who couldn't tolerate alpelisib that I utilized capivasertib. But this is a patient who's 52, postmenopausal, strongly ER positive, 95%, PR negative, HER2 2+, non-amplified, so HER2 low, presents with liver metastasis. She takes ribociclib letrozole for 6 months. She had de novo disease and had, just to go to the point that you were making, she had a limited time on this treatment where she developed 2 small new liver lesions. She underwent ctDNA. We detected a PIK3CA mutation, E542K. She also had an AKT1 E17K mutation, asking the question, what would you think about next?
Hope?
Well, so I actually have a patient, but unfortunately she's 32.
I knew she was going to say, I've had a patient just like this.
Yeah, I always have patients like this. Yeah, I mean, I don't know. The patient same, look fabulous at 6 months, and then she got an MRI to see because she had de novo metastatic disease, and 3 weeks later she had a liver met, and 6 weeks later the liver was full of tumor. It was just really dramatic. She has a PIK3CA mutation, and we did a liver biopsy, and it was ER negative. But we had just done a breast biopsy, 6.5 months before, so I gave her giredestrant and inavolisib on the Morpheus 2 trial. She had a fabulous response at 6 weeks, nothing was there, and at 12 weeks it was all back again, and we took out her ovaries and they were full of ER negative cancer. So, these cancers can be hugely unstable, but in any case, in this case, I would treat in this situation with capivasertib and fulvestrant.
We actually, and Kevin's about to discuss this, but we've had a couple people already asking, Joyce, maybe you can comment on how you prevent and manage toxicity with CAPI. So before we start hearing the data, what do you do, Joyce?
Well, I use BID non-drowsy antihistamines to prevent rash. I don't start prophylactic mouth rinse, but I just tell patients about it because it's not very common, but the dexamethasone prophylaxis. I tell them about diarrhea. Just eat the bland diet to start off with, and it's not bad, though, because you get the 3 days off, but use the loperamide, stay well hydrated. Those are the main ones. Oh, well, the sugar. I do tell patients, eat a low-carb diet. Eat a low-sugar, low-carb diet. I don't have them with alpelisib, I have them do finger sticks at home daily, but I don't do that with the CAPI.
Just curious, do you agree with Dr. Freemel's earlier statement? And she said, I've had a lot of patients with alpelisib who did well, I had a couple who didn't do well. A lot of times I hear people have used it once, had a bad experience. Globally, Joyce, what is your experience? Do you have people who you could get on it and they tolerate it well?
Yeah, it's a real mixed bag. Now I must say that when it first came out, of course, I was giving it to my very late line patients and they did not tolerate the full dose. But I have patients who have done very well in general. If there's any concern about their performance status, I do start at a reduced dose. I start at 250 rather than 300. But if they're robust, so it's a mixed bag. But it is the glucose is challenging because it's an on-target effect. And I have found that patients who are benefiting are the ones whose sugar goes way up. And so I have found you cannot cheat. You've got to have a hemoglobin A1C less than 6.5%. It has to be that way. And then I start metformin prophylactically per the Metallica trial, and you can ease on up, and we see them every 2 weeks. But I have them do finger stick and bring their data, and gotta eat the low-carb diet.
Interesting.
But how
Kevin, what's the follow-up to your patient, and then we'll get to Hope.
Well, this particular patient went on to fulvestrant plus CAPI. She's been on for about a month.
And how's the patient doing tolerability-wise?
Great. She's tolerating it very well. I will also say, this is a patient, we checked the hemoglobin A1C, it was normal, she's a thin patient. She's had no toxicity.
How do you kind of prepare people to take 4 days, 1, 3 off? Is that an issue? They have like blister packs or something?
Mm-hmm. Yeah, that's exactly right. But, to me, that's actually one of the most complicated aspects of taking the drug, right? Of taking it 4 days in a row, twice a day, then being 3 days off. And that's something that we reiterate, and we also have a pharmacist who sits with us in the outpatient setting, and she follows up with these patients, and it has made our lives much easier. It couldn't exist without her.
All right, let's talk about some data.
All right, so let's talk PI3K AKT pathway alterations. So as we've been discussing, alpelisib was approved for patients who have PIK3CA mutations. This is based upon the SOLAR-1 study. So just to remind us, in this particular study, these are patients that had tumors that had progressed on prior aromatase inhibitors. And this study included both patients with PIK3CA mutations as well as patients who were PIK3CA wild type, and randomized them to fulvestrant with or without alpelisib in a placebo-controlled trial. Primary endpoint, when we look at PFS, we saw a near doubling of median progression-free survival. OS was a key secondary endpoint. In this study, we did not see an improvement in overall survival. One of the limitations from the SOLAR-1 study is that few patients received prior CDK4/6 inhibitors. That was underrepresented, just given the timing of when that study was enrolling patients. So we now have had the data from the BYLieve study, which have been presented by Hope, which have different cohorts of patients. These are patients in the post-CDK4/6 inhibitor setting. This is a pragmatic study. In this particular study, patients, there are different cohorts that patients could have gone on to if they, depending upon the type of endocrine therapy that they had in the past, with the primary endpoint being looking at the number of patients that were alive without progression at 6 months. So when we look at the BYLieve data, cohort A are patients who had prior aromatase inhibitors, cohort B were patients who had prior fulvestrant. You can see that about 50% of patients were alive without progression at the 6-month time period, which met the endpoint that was being looked at. You can see the median PFS is somewhere around 6 to 7 months, and you can see that there were some responses that were seen, about 20% or so, with giving alpelisib plus endocrine therapy after patients had received a CDK4/6 inhibitor. So when we compare these two trials, again, there was a small population. You see, it's just 20 patients from SOLAR-1 who had prior CDK4/6 inhibition. And we have the data from the BYLieve study, a much more robust data set of patients who had prior CDK4/6 inhibitors, albeit to say that this rate of having, being alive without progression of disease at 6 months was similar between the two studies, but a very small population in SOLAR-1. So we've already spent some time talking about the CAPItello 291 study. There have been phase 2 trials like the FACTION trial, which had generated enthusiasm about the role for capivasertib, which is AKT inhibitor, for patients with metastatic breast cancer. So in this particular study, patients could have had up to 2 lines of prior endocrine therapy for advanced disease, no more than 1 line of chemotherapy, and prior CDK4/6 inhibitors were allowed. We were not allowed to have prior PI3K inhibitors, for instance, and also no prior mTOR inhibitors. So in this population, these are patients that did not receive everolimus or alpelisib. So there was a 1-to-1 randomization of fulvestrant with or without capi. Again, in this trial, it included all comers, and then looked at those patients who had alterations. You can see circled here just the percentage of patients who had prior CDK4/6 inhibitors. So it's about 2/3 of patients had prior CDK4/6 inhibitors. This is a slide that is just demonstrating the type of PI3K AKT pathway alterations that were seen. The majority had PI3K mutations. There were a few patients who had both a PIK3CA and an AKT1 mutation, like the patient that I presented, that is my patient. And there were few patients who had PTEN-only alterations. So these are data that are looking at the overall population, which is the curve you see on the left, and then the AKT pathway population on the right. And if you look at the overall population, there's a hazard ratio of about 0.6. That hazard ratio was a little bit better if you look at those patients who had AKT pathway altered disease. Also, as we've been discussing, the side effects we can see with this agent include diarrhea, rash, nausea, and vomiting. The rate of grade 3 diarrhea is less than 10%. Also, Joyce had mentioned rash, and then the rate of having high-grade hyperglycemia is low, but we do see some all-grade hyperglycemia. So one of the questions that had come up before we saw the FDA approval for capivasertib this last fall was that there was that population who had non-altered disease, for which we did see this hazard ratio of about 0.7. It is important to know that in this population, this included patients that were pathway unknown, and we weren't sure if we were going to have approval for all comers. But as we found out in the fall, that this was specifically approved for patients who had alterations in the pathway. Joyce had mentioned the Innovo 120 study, which again was giving the triplet of novelisib plus palbociclib plus fulvestrant. I talked about SOLAR-1. I talked about CAPItello 291. This is a slide from Hope's reporting. We talked about it at San Antonio. She gave the discussion in the Herculean effort of getting these slides together in like a moment's notice. And so this is just showing the toxicities that are seen across the different trials: hyperglycemia, diarrhea, rash. We talked about the differences between the agents. But one of the things that I want to mention 2 things. One is just the hemoglobin A1C requirement that was different across all the studies. You can see in ANOVA 120 that hemoglobin A1C cutoff was 6%. For SOLAR 1, it was 6.5%. And for Capitello 291, it was higher. It was 8%, for they had the greatest leniency. The other thing just to note with giving inavolisib, if this gets approved with the triplet, is we did see stomatitis. The oral steroid rinse is not globally available, so not all countries had access to giving this prophylactically. But if this drug gets approved and if it's given along as a triplet, giving prophylactic steroid rinse is helpful for this agent. These are the ASCO guidelines, which is just reiterating the role of PIK3CA mutations for hormone receptor positive metastatic disease, that patients should undergo testing for PIK3CA mutations with next generation sequencing either of tumor tissue or ctDNA, and just making the point that if it's not detected in ctDNA, to think about looking at it in the tumor tissue, per the comments that we've made, that this is something that is often seen in the primary. And then I just want to make a few additional points before I conclude. We've talked about the inavolisib 120 study. There are other studies that are looking at inavolisib. There's an ongoing study now that's looking at prior CDK4/6 inhibition plus endocrine therapy that is randomizing patients 1-to-1. This is the first head-to-head comparison of PI3K inhibitors. It's comparing fulvestrant plus inavolisib, which is given daily, versus fulvestrant plus alpelisib, which is also given daily, with the primary endpoint being PFS. And then there is also the Inavo 122 study. We've been talking about ER-positive disease. This is looking for patients with HER2-positive breast cancer, which have PIK3CA mutations, which is randomizing patients after Cleopatra-like regimen to receive pertuzumab, trastuzumab, with or without inavolisib. And the primary endpoint for this is PFS. And then I also just want to mention Capitello 292. We talked about Capitello 291. So this is a phase 3 study, which is looking at a similar population, somewhat similar population of the Inavo 120 population, which is looking at patients who had distant relapse while on or within 12 months of their operable endocrine therapy, which is randomizing patients to fulvestrant CDK4/6 inhibitor with or without capivasertib. And this is also per Dr. Rugo from her discussion, which is just to make the point of the different agents that we've had available and where we've come so far. I really just wanted to make the point that we are also entering the era of mutant selective agents that target PI3K. For instance, there are agents that target H1047R specifically that may have less toxicities, and then we're also going to start to see AKT mutant inhibitors as well.
I thought you were going to say bispecifics and CAR T.
Those are coming too. Those are coming too.
All right. So, Erika, some good questions coming in from the audience. From Mary, what about Cappy after alpelisib or vice versa?
Yeah, I don't think we have any data about that. Hard to say. I mean, I would think that you're probably not going to see a whole lot of activity of one over the other for a targeted agent like that. We haven't looked at it.
So, Joyce, a question from Cavi. It's kind of what I was trying to get into before. You have a patient who's got first-line endocrine therapy or metastatic with CDK. The disease progression has visceral disease, very symptomatic. Are you going to think about chemo or an antibody-drug conjugate to sort of cool things down and maybe come back second-line endocrine therapy, or just keep going with endocrine therapy?
I think this is a very important question because this is after the CDK progression. The disease can be more resistant to endocrine therapy. Sometimes we only get 6-7 months even after second line. And this is the art of medicine. I think we have to recalibrate. We love to go with line after line of endocrine. What I have learned is, in this situation you just described, I better switch to a cytotoxic because you can lose your window of opportunity, and people can lose their performance status, their liver function, because you can come back. You can come back to an endocrine therapy. So I would go with a cytotoxic therapy if somebody's rapidly progressing in the liver.
Cytotoxic ADC?
Yeah. Mm-hmm.
So let's go to this next case, but before we actually get to the specific case, I'm just kind of curious, Kevin, because it's kind of something I've been thinking about in general. what your second line, and we're talking a lot about second line endocrine therapy tonight after CDK. What's your second line therapy in a patient, let's say, who had a BRCA germline mutation?
It still depends on how long they were on their prior endocrine therapy. And if they have endocrine sensitive disease, I still continue endocrine-based treatment. And then, for me in general, I tend to go to PARP inhibitor when I'm thinking that they may be endocrine resistant. That's
Second opinion?
Yeah, I know. I totally agree. I had that patient. That's just my last follow-up on the patient with the ER negative. So she comes back, she's progression at 12 weeks on the giredestrant and inavolisib, and everything is ER negative, but she has a BRCA2 mutation. So I started
Somatic?
Germline. So a germline BRCA2 mutation. First time, nobody knew in her family before. And also, we had data on alpelisib after everolimus where there was efficacy. So I do wonder if we're going to see something, if you give in the very endocrine sensitive patients. I just don't know how we're going to get the data because we have so many treatment options now.
Kevin?
Yeah, I just wanted to talk about that one patient and I don't know if anybody else has experience of somebody who really could not tolerate alpelisib. I have this highly compliant patient, keeps a journal. Her husband has a spreadsheet of all of her glucose multiple times a day. She was on 2 oral drugs, went on to treat her hyperglycemia, went on to insulin, and I thought, okay, it's too much. Put her on Capi, doing great. Off the insulin, titrating off her other agents as well, just to me demonstrating that it's a better drug for that side effect.
So just to squeeze in a little bit of PARP, here's the case. And actually, this patient had a PAL-B2. The prostate people call that BRCA3, but here's the case.
My question to the experts is, what therapy options will be best for her if she develops progression on olaparib?
What would you be thinking?
I would probably do the capecitabine and then the TDXD because she's HER2. Now she's 2+ low. That's what sort of I was thinking.
Any other questions?
We know that the PARP inhibitors are approved, indicated for the BRCA1/2 germline genetic mutations and somatic mutations. But I guess how often do you see actionable in the terms of you've used PARP inhibitors for non-BRCA germline mutations or somatic mutations? And is it hard to sometimes get those approved? Other than the PAL-B2 and the BRCA mutations, are there other germline mutations that you would try to get a PARP inhibitor approved for in a patient like this?
So, Erika, of course, you're deeply involved with ovarian cancer, and this has gotten looked at in great detail there as well. How do you think about other mutations in terms of the use of PARP?
Yeah, I like that BRCA3. I'm going to have to start using that. I'm going to steal that line from you. I think we've got a good body of data now that we definitely can see activity with the PAL-B2. Variable with some of the other mutations. We've looked at it, and it doesn't, sometimes it's hard in breast cancer just because you have a mutation. A lot of these people have multiple mutations. You don't know what the driver is, right? Car analogy, something's the driver, but there's other passengers. And when you look at a molecular profiling report, it's hard to say what the driver is. I think, it definitely reimbursement can be an issue too, but there's a lot of trials ongoing in that area.
I think there's one case, one of your cases had check 2 or something. Check, what is that? How about check, no?
I can't
ATM,
tell you.
Nothing?
I spent countless hours looking for the synthetic lethal for germline check 2. It doesn't exist yet. There are trials going on inhibiting, DNA PK and such, because when you've got a germline, every cell has it. There's going to be a synthetic lethal for that, right? It doesn't exist yet. And the data we have so far with PARP inhibitors does not look good with check 2. Now, I think in prostate, they've seen it, though. I think in prostate, other malignancies, that may not be the case, but we don't have the data in breast.
Yeah, we're going to talk about that tomorrow. All right, Hope, antibody-drug conjugates. Never thought somebody would give an entire talk on antibody-drug conjugates in breast cancer maybe 5 years ago, but here it is.
And worry that you don't have enough time.
Exactly.
So let's see, there's my pointer, sorry. So we'll do the case first. Disclosures, case. So, and I am going to hopefully be able to read from here, those little tiny writing. So,
how about if I cut to the chase here, because I think it's the bottom
I'll
part.
be quick.
Okay.
So She's 61. She had prior chemo. She's in the military. Lots went on. She had a left breast local recurrence with a lot of positive nodes, and then had a recurrence in axillary fat, and then metastatic disease to the brachial plexus, which is just a torturous site of disease because of the arm issues. And she went on to fulvestrant and palbo. Remember, this was a long time ago, after radiation, 2019 to 2020. Pretty good response. Has a PIK3CA mutation, and as you said, similar to Kevin's case, she took a week of alpelisib and had like swelling of her mouth, and I was just terrible allergic response. So we switched her to exemestane and everolimus, which was complicated, unfortunately, by grade 2 pneumonitis treated with steroids. So then she got capecitabine with progression in her liver and had ER-positive still disease. So she was randomized on Tropion Breast-01 that we'll briefly talk about, and was randomized to standard of care chemo and had gemcitabine with the response, then PD. In liver. So I gave her TDXD because I told her, you can go on this trial, it's all fine, you'll get TDXD as standard of care. So she got TDXD and got short of breath and started coughing.
Could I just ask,
10 days.
Did you have any concerns about giving her TDXD given she had grade 2 pneumonitis with everolimus?
Well, we don't have that data, but I said to her, you had pneumonitis before, but it was brief, grade 2. I gave you steroids. Within 2 days, she was better. We tapered her off. It's pretty minimal. We don't know that it's the same etiology. It probably isn't, because we don't have to treat grade 1 for everolimus. So
when you look at the TDXD data, you don't see a difference there?
Well, you have to treat grade 1 for TDXD, because once you go on to grade 2, there's the risk that you might not be able to have it be reversible.
I was just asking whether or not because a lot of oncologists ask that prior pneumonitis from another drug is higher incidence with TDXD.
We didn't have that data, and we couldn't unearth it out of the database. We're actually presenting a pooled analysis of risk factors for ILD at ESMO Breast, and it's interesting because in the pooled analysis that's published by Pauls, renal insufficiency is a big risk. Now, for the studies, you couldn't have had prior ILD. So we're never going to find that. It's all going to have to be a real-world analysis, and I don't even know that Flatiron would help us with that. So I think we're going to have to bring together anecdotal cases to see. I have treated another patient with TDXD who had prior pneumonitis. She did fine. So this patient did not. She was symptomatic within 10 days, treated with steroids, and went on to sacituzumab, so she was lucky to have an option. And she had about 6 to 7 months of excellent response, excellent quality of life, spent a lot of time with her grandkids, and then progressed. She's now, that was May of 23, she's still alive on therapy, responding to eribulin. So, these patients we treat with sequential therapy over time.
Interesting, and interesting the sequencing there. So this is a question I was just sort of curious about in terms of how people manage ILD. I'll go to you, Erika. This is a theoretical case. I was just curious how you would answer. So 62-year-old woman, HER2 low, gets started on TDXD, 5.4 milligrams per kilogram. After cycle 3, she has grade 1 ILD. Started on the corticosteroids. It takes 6 weeks to resolve. What do you do? What do you do, Erika?
So the caveat is it had to resolve within 4 weeks on the clinical trials to restart. But that was challenging because even when you started steroids, like they may be looking a lot better, but to completely resolve, lung inflammation can linger for quite some time. So I probably would feel comfortable with this patient, grade 1, resolving within 6 weeks. I would restart them. To be quite honest, trastuzumab deruxtecan has such significant benefits that not giving an opportunity for a patient to continue that really can have side effects as well, right?
So what dose do you start, though?
I've done both, and I've done dose reductions. It kind of depends on what other symptoms they're having. I'm not super convinced that ILD is really dose dependent.
Joyce, second opinion?
Yeah, I would restart this patient, and I would go down. It makes no sense to me to restart the same dose, so I always go down, and I do the non-contrast chest CTs to find it asymptomatic for this exact reason.
Okay, again, we'll talk a lot about TDXD tomorrow, but we're going to talk about it here now.
We're going to present data on a pooled analysis of retreatment at ESMO Breast also,
Awesome.
So there'll be a lot more data on this. And indeed, it's 6 weeks, the recommendation.
Like everybody in oncology is looking at this now, right?
Yeah.
It's all really over oncology, GU, GI, everybody, and they have no idea about TDXD, believe me. Sorry, don't quote
the party
me.
line would be retreat and dose reduce. So as people say,
Right, retreat
because
dose.
it's 6 weeks. If it's less than 4 weeks, you
Right.
don't dose reduce.
Right.
So Okay, so we're going to talk about antibody-drug conjugates, and this is just a partial list of some of the antibody-drug conjugates. We have 2 that are approved, as you know, sacituzumab govitecan and trastuzumab deruxtecan. We have phase 3 positive data on datopotamab deruxtecan, the second TROP2 ADC that we have. We have a whole party of TROP2 ADCs that are being studied, one already entering into phase 3 trials. And then the HER3 ADC that Erika has the most recent data on, patritumab deruxtecan, as well as others. And they're, really what we're going to focus on are the ones where we have phase 3 data, and we'll talk briefly about patritumab. And now, so one of the things that's really important here is to look at these different characteristics. So antibody linker payload. So we know the antibody plays a role, but it's amazing that we can target cells that don't express much of the target with these very high potency antibodies. And then the payload, of course, is important. We like to have variable payloads. But the linker turns out to be much more important than we understood. We knew it was important for TDM1 not to cause off-target toxicity. But it turns out to be really important for delivering the drug, not just to the cell that you've targeted, but also to cells that don't express much of the target, the so-called bystander effect. So there's been a lot of changes in linker, and these different ADCs are continuing to improve the linker technology. So, of course, the data that was so nice to see right after the pandemic, our first in-person meeting was DESTINY-Breast04, looking at trastuzumab deruxtecan versus treatment of physician choice in patients with the primary endpoint being HR-positive, HER2-low metastatic breast cancer, who had received a median of 1 line of prior chemotherapy. About 70% received prior CDK4/6 inhibitors. This data was updated at the ESMO Congress, and of course, PFS is no longer by blinded independent central review, so the hazard ratios are all different, but the results are very similar. As you can see, there's a big separation for both PFS, and of course, OS continues to be significantly improved. Although, interestingly, the difference in PFS is greater than the difference in OS. So it's not the same as giving trastuzumab to HER2-positive disease where we see a bigger OS difference than PFS. But this difference has been maintained. It continues over time. This is very small, but you have the slides, the subgroup analyses of OS in the HR-positive cohort, the primary endpoint, and adding the small number of patients, 58 patients with ER-negative HER2-low disease showed that it was efficacious in all cohorts. There was no new safety data. Nausea is the most common toxicity. There was 1 additional death from ILD, making the overall mortality 1.1%, but that patient already had ILD, but it progressed over the time from the data reporting in the New England Journal and this updated reporting. So there were no new cases of mortality, which was certainly encouraging. And most of the ILD, as you can see, is grade 1 and grade 2. There's really very small number of cases grade 3 and no grade 4. And then this is the pooled analysis I was talking about earlier, published by Pauls. And again, there will be an update at ESMO Breast. We'll have, I think, very important data. But you can see the things I've circled here, being older, having more prior treatment, and more significant renal insufficiency. If you're going to treat a patient who has more significant renal insufficiency, you really have to screen them more closely. The overall incidence, about 12 to 15%, depending on the study, and about 87% occurred within the first 12 months as their first event. So that's where we really need to be screening patients more carefully. As you know, you hold drug for grade 1 asymptomatic ILD, and I treat with 0.5 milligram per kilogram steroids and rescan at 3 weeks, hoping that they'll improve. And I have to say, I do treat even when there is a little bit of ground glass opacity left, because it's hard to get rid of it. If you have a cold or something, you have it. And then we stop permanently for grade 2, and this is an interesting area to look at in the future. We all know DESTINY-Breast06. We're waiting for the results. We hope by the end of this year. This is an 850 patient study in the first-line chemotherapy setting, and it includes 150 patients who have less than 1 plus HER2, but not 0, so-called ultra-low. So very important study results that may change our clinical practice. And then sacituzumab govitecan, which improved PFS and OS in metastatic, heavily pretreated triple-negative disease, also improved PFS and OS in patients with a median of 3 lines of prior chemotherapy for HR-positive, HER2-negative disease, all of whom had received prior CDK4/6 inhibitors. And there was really a marked difference in this patient population in those who were progression-free, 3 times as many with SASI versus chemo at 12 months. And then we've also looked at safety for tropics for sacituzumab. A big contrast, the most common toxicity is neutropenia. We don't see ILD. And then diarrhea, which appears to be associated with polymorphisms in UGT1A1 with the STAR28 homozygous clearly having more diarrhea and more significant neutropenia. But there wasn't more febrile neutropenia and there weren't more discontinuations due to neutropenia, which was helpful. Another difference between TDXD and sacituzumab is there's more complete alopecia with sacituzumab than TDXD, and sacituzumab is given day 1 and day 8 every 3 weeks versus day 1 every 3 weeks. There are a number of ongoing trials for SACI2. The post-neoadjuvant SASKIT trial has a component of HR-positive disease with high-risk residual disease. There's a trial out of Dana-Farber looking at HR-positive disease with or without pembrolizumab in the first-line setting, and then the phase 3 ASCENTO-7 trial looking at SASI versus first-line chemo in first-line SASI versus first-line chemo in HR-positive metastatic disease, and that trial is accruing very rapidly, actually. We hope to see completion of accrual this year. Datopotamab deruxtecan is also a TROP2 ADC that has deruxtecan as the payload. It has a lower DAR, but clearly is delivering drug very well. It improved progression-free survival in patients with HR-positive metastatic breast cancer at a median of 1 line of prior chemotherapy, and it also delayed time to first subsequent therapy. And in general was well tolerated as well. Here you can see the overall safety and the AEs of clinical interest. Neutropenia is not seen as frequently, so it's really similar to TDXD. But unlike TDXD, you see more stomatitis and less ILD. A little bit of ILD, not much, but grade 3 stomatitis can be seen in about, somewhere in the 6% to 8% of patients. And we've been using the steroid mouthwash with much improvement in the I-SPY2 neoadjuvant trial, but not completely no stomatitis. There's still some patients who get grade 3 stomatitis. It responds very well to dose holds and dose reductions. So we'll see that when we have the drug.
So do you think it's not quite as effective as, say, with everolimus?
The steroid mouthwash?
Yeah.
It's an interesting question. So we really didn't see any grade 3 stomatitis when we used the mouthwash for everolimus. I will say that the complication TROPION-Breast01, although we had this very, a lot of meetings, we told everybody the steroid mouthwash, it's not available everywhere. Sometimes people have to compound it. So it's not clear if people started it when they had mouth sores or were using it at the beginning for all the patients. Now, in I-SPY, we just gave 4 doses. And in general, steroids worked really well, but there were still a few patients who escaped. So I think we're going to have to understand that over time.
Yeah, the lung people are trying to deal with data, but they have no experience with this. We've been telling them about that. So it's interesting that you find it works well. Please continue.
I think it will become a standard along with other procedures that people are using. So there are ongoing trials with Dato-DXd in ER-positive disease. So ER-low is included in TROPION-Breast04, a neoadjuvant trial, but it's ER-low that we think is really triple-negative, so 10% or less ER. Actually, I think it's less than 10%. There's not an equal there. And then I-SPY 2.2 looked at Dato-DXd or Dato-DXd and Durva, and that's not, we're not comparing the two. We compare it against control, historic control, and that is completed accrual, and we hope to see that data a little bit later this year.
Yeah, first line, we're going to talk tomorrow, first line therapy of metastatic bladder cancer in the last few months flipped from cisplatin-based chemo to IO, Pembro, plus ADC and Fortimab, and they beat cisplatin-based chemotherapy to death, and that's
that was very impressive data.
Yeah,
indeed.
so maybe we'll see.
Well, I think that then it's the issue in bladder cancer. You don't stay on things forever, but you do in breast cancer. So the whole idea is tolerability.
Well, the thing that interests me though is we know about chemo and IO, but the idea of ADC and IO, I don't know if that's the same as chemo and IO or maybe more effective. I don't know.
I think the preclinical data suggests, and some clinical data, that potentially by giving an ADC and IO that you enhance the efficacy of the IO, so there may indeed be some synergy there. So it's going to be very interesting to see the ongoing trials in triple-negative disease. Patritumab and data presented by Erika, they had hormone receptor-positive triple-negative and HER2 disease. It didn't matter whether or not you expressed HER3 that we've seen. The responses were very nice in a group of patients, some of whom had been fairly heavily pretreated, and as you can see in the little spaghetti plot down there, they were very well maintained. There's a lot of new ADCs. These are just a few examples. SKB264, which is now MK2870, is a Merck drug where they partnered with a company called Kalen, and they are starting a phase 3 trial in the post-neoadjuvant setting in triple-negative breast cancer and in the first-line HR-positive setting, similar to ASCENT-07. And that study actually is now posted on the NCI website. There's some other really cool ones. So, for example, Bolt Bio, where Edith Perez is the CMO, is looking at a trastuzumab linked to a TLR7/8 agonist. It's an immune effector molecule. There's a B7H4 and topoisomerase ADC, which is fascinating. There's trastuzumab linked to eribulin. That's a cool drug, too, different payload. And then a cool drug that has a HER2 antibody linked to a STING agonist. So lots of different things going on here. And these trials are in phase 1 to 2 trials. The combination therapies looking at ADCs plus checkpoint inhibitors or other immune agonists are ongoing. ADCs plus anti-CD47 antibodies, I don't know, magrolimab is sort of dying, and so that may not move forward with this specific anti-CD47, but maybe others. Understanding mechanisms of resistance is a huge area of research, of great interest, and a lot of our colleagues are working on this. And then sequencing ADCs, trying to figure out which patients need a change of the payload or target. Why is safety so different between different TROP2 ADCs that have a similar payload? It's really not well understood. And I just highlight the data from my colleague Laura Hubbard, who did a study working with our colleagues around the United States and gathered together sort of registry data and looked at what happened. And similar to the other studies that have been done, the patients generally have a better PFS to the first ADC than the second. But the challenge to all of us, there's some people have a better PFS with the second ADC than the first one. So understanding who those are is incredibly important. We have a sequencing study called TRADE-DXd that's looking at TDXd and Dato-DXd, and then a registry sequencing study Laura is running, and then another study that Rishma Matani here in Florida is running, a multi-center study looking at SASE after TDXd. So at least 3 studies in the US. So I'll just leave you with some ideas for a roadmap for the future. So for early stage disease, that's where we really want to move these ADCs. They work so well. We really want to cure our patients so that we're not dealing with metastatic disease. So maybe we could actually use gene expression panels to try and understand who needs checkpoint inhibitors, look at PD-L1. We'll talk about some more tomorrow. And then add an ADC either up front or for patients who are having a poorer response before surgery, so we don't end up with more and more resistant disease, and then use alternative ADCs in those with still high-risk features. For the metastatic setting, in general, we do want to use endocrine therapy with targeted agents, but I think that we may in the future find a group of patients like Joyce was talking about who have visceral dominant disease, very short disease-free interval, low ER, where we might want to do an induction with an ADC and then use endocrine therapy with a targeted agent as maintenance. So there's a lot of ideas that we can think about in the future. Many questions remain, but it's really an exciting time.
So we come to this last discussion, and we call it breast cancer in the real world. I thought we could just take a breath. You were about to roar through a lot of data in the next 2 days, and I'm pretty, our motto is all day, and that's the way it's going to be, just like it's been the last hour and a half. But I just thought we could take a deep breath and just think a little bit and just bring up, sort of the patient end of this. And I mentioned our interest in clinicians with cancer. You heard from Dr. Friemel. And I was referred to a woman who's a neuropsychologist at a hospital here locally in Broward County, works in the pediatrics department doing neurologic assessments, sees a lot of oncology pediatric patients. She moved to Miami 5 years ago and wanted to have a child. She had a 2-year-old. She got pregnant, and shortly after becoming pregnant, discovered she had a breast mass that was ignored by a couple people. She persisted and had locally advanced HER2-positive ER-negative disease. She got AC during the end of her pregnancy. After the pregnancy, TCHP, not very much of a response. Had TDM after that, had neratinib for a year after that, and like many people who go through this experience, it was a war, and she was a warrior, and now it's 5 years later, and I thought it would be interesting just to bring some of her reflections of her experience. And, the faculty was like, well, what do you want us to say? Just say whatever you want, because, I could not even come here tonight, just let the four of them talk, and it probably would have been better. But in any event, just want your thoughts. I'm just going to go to you right down the line. I'm going to start with you, Joyce, after you see the first video. Anything that pops into your mind, any thoughts you have about taking care of patients in this interesting world that we live in. Here are some photos from this woman during her treatment. And again, she had a 2-year-old, and you can see in the lower right there the picture of her when she was pregnant. And again, everybody here in this audience has seen these pictures before. Here are some of her thoughts. We'll start with this in terms of the experience for her.
I mean, I think that was the most stressed and anxious I've ever been in my life. It was very hard looking up information online that was not positive, thoughts of what's going to happen to the baby. Can I keep this pregnancy? I was told, the placenta should do its job and protect her during the AC chemo. The bigger risk factor was if the baby's born premature. And in my practice, I see a lot of kids who are born premature. And so I've seen those outcomes.
How about the chemo?
That pretty much wiped me out completely. I lost every hair I had been hanging on to. I had uncontrollable diarrhea. I ended up on a morphine tincture to try to control that. So fortunately, I was home for 12 weeks on maternity leave. So while my body was really being destroyed by this, at least I wasn't going to work every day. I was able to rest. I continued working, which for me, I needed to financially. But in retrospect, too, I think it helped because I had to focus certain days and certain times more on what I was doing and my patients. I couldn't just sit there and dwell. I'm the breadwinner for our family. My husband works, but, the bills don't stop just because you have cancer, and all of these co-pays for all of the visits add up. The hospitalization bills add up. So I really didn't have a choice in the matter, but yeah, I worked the whole time.
So you were pregnant, on chemo, bald, and still seeing patients.
Yes.
How did they respond?
No one said anything. I mean, for sure, I think after I came back from maternity leave and I had lost every single eyebrow and eyelash, they probably wondered, I would think, but nobody said anything. So I don't know.
So Joyce, I was mentioning fellows, and we know a big part of our audience has been in oncology, less than 5 years. Any thoughts?
Well, I'm just struck by how young mothers will do anything and everything, And then sometimes young women who are not married yet, who do not have children, are more focused on the toxicity, of things, where she's completely focused on survival, and that's very, very common. But, I think the anxiety, what I would have felt, and I think she would have felt too, she's got a locally advanced ER negative, HER2 positive, like, how long do we have to wait till we start the AC? That's because these are rapidly growing things, you know what I mean? So that would have been extremely anxiety provoking.
And, just the experience as a physician or nurse to see somebody go through and land here is, I don't know if anything that happens outside of our field. So, Erika, I'd like you to respond to this thought. We talk a lot about involving patients in decisions, and Dr. Ortega actually goes beyond that and saying encouraging advocacy, not just allowing it or considering it, encouraging it. Here's the way she expressed it to me.
I think from all ends, helping patients understand that it's okay to advocate for yourself is important. Before, because I never really had many medical appointments, even within the medical field, I just had this image of, well, every doctor kind of knows everything, right? But no, you may need to go see other specialists and track down different answers, and that's okay. But also, if you feel strongly that something's wrong or something's off, it's okay to speak up and keep advocating for yourself. I've certainly learned that throughout this whole experience. And so for physicians to understand that patients can and should advocate for themselves, and also for patients to know that that's okay and you should speak up.
Erika?
Yeah, I mean, I think a lot of times we underestimate this, right? People not telling us about side effects because they don't want to be perceived as whining, right? I mean, really, I want to know how you're doing. Like, we're in this together. Like, please tell me, because there's things we can do. There's medications to help with side effects. There's dose reductions. And similarly, I have patients that come to me for a second opinion, and they say, please don't copy my doctor on the note. I don't want them to know that I came here because I feel bad, right? I'm like, you should never feel bad. Like, we're not in this for ego, and, everybody should get a second opinion. It's just reassuring to hear even the same thing said in a different way, because when we're giving somebody, information in a room, it's a lot at once.
Kevin, I've got to say too, our work in education has totally changed since the pandemic. I mean, the ability to generate content now online is unbelievable. But I was thinking the same thing was going to happen in medicine, in oncology and medicine, in terms of telemedicine, second opinions. It doesn't seem like telemedicine has taken off.
Well, part of the limitation, I think, is, I am only able to see and bill for patients in a state for which I am licensed. And I think that it is limiting our ability to reach out, get second opinions, et cetera. I mean, I have patients, I'm in Georgia, I have patients who are in South Carolina. They have to theoretically cross the state in order to do a telemed visit with me. And so it is one of those barriers, not just clinically, but like research-wise as well, that is something that is, I do think, impacting our care.
Yeah, this needs to get fixed, including with research. Hope, you've worked with us many times in the ONS meeting. As a matter of fact, we have that coming up in a few weeks in Washington. And one of the things we've talked about there, we've also talked about in physicians programs that they have a great interest in, though, is the issue of patients with minor children and minor grandchildren, particularly patients who are not going to do well. I mean, this woman, at this point, at least has survived this whole scene. But this, she takes care of children. So I was curious what her thoughts were about dealing with minor children. Usually when I ask oncologists, particularly in tertiary centers, you guys often have resources out in the community, maybe not so much. And here are some of her observations, both from her clinically as well as personally.
I think just finding age-appropriate ways to communicate what's happening is really important, whether it's through books or just trying, like if you're in the hospital setting, using Child Life, because where I've seen more difficulties are where parents may refuse to name it when kids are older and can understand. So 10, 11, 12 teenagers. And sometimes they're being taken to appointments where it says cancer center and parents aren't telling them why they're there. And then I've seen a lot more anxiety, a lot more emotional issues because of that. Because I think if parents refuse to name it, but kids know when they're a certain age, I think that also creates this underlying anxiety or this fear. We can't ask questions. We can't say anything. And so I think when they get older, it is really, really important to try to find age-appropriate communication to explain to them what's happening in at least a basic way.
Hope?
Yeah, I mean, I think it is incredibly important. And a lot of times people feel like they're protecting their family, their parents, and which maybe elderly, and their children. And in general, I think it really comes back to bite you and the kids too. I had a fascinating program I did with a very well-known, nationally, internationally known advocate who's a retired OBGYN, happens to be my patient, lives in a rural area of California. And when she had breast cancer, even her early stage, her daughter was a teenager, and the daughter was on, and it was actually it was like a little off-putting, but the daughter was really mad about that time in her life. She felt like she was put apart. She was an only child. She was separated. She didn't know what's going on. She wanted to be the center of attention, not her mother. And it's just a normal thing. So I was just thinking about it because I have a terrible colleague who came in with a little tiny HER2-positive breast cancer and has liver mets, and she has a small child. And because we've been so overwhelmed with their diagnosis ourselves, I mean, sometimes for us, it's hard, right, to talk to people about those things because it feels so close to you. So in this case, I realize we haven't really talked about her 2-year-old. This 2-year-old's a little young to talk about it, but she's going through chemotherapy, has metastatic disease when she walked in the door at 39. So, and she's a physician. She knows what this means. So I need to go back and talk to her more about that next week.
So Joyce, her perspectives on her oncologist and her nurses.
He's fantastic. I love him. I see him, I work here, and so I'm able to see him sometimes in the physician's lounge, but he's always been really available if I do have something that's come up. So whenever I was having random side effects, like I had hand-foot syndrome, I could send a picture and say, like, what is this? I feel like he always really listened to me. I tend to be a little more anxious. I never felt rushed in an appointment with him.
Any observations on nurses that you encountered along the way?
My chemo nurses were extremely helpful in trying to come up with other ways to address side effects that I was having. You could try this, you could try that, things like different spices or that sort of stuff that they were like, well, this has helped other patients. And I felt like they were really my go-to for other things like that. And so I think the chemo nurses really became my friends. I spent a lot of time in that chemo chair over 2 years. I still keep in touch with some of them. So they were extremely helpful to me.
Joyce, sometimes I see meetings like this and it almost reminds me of a temple or church. That we're here to learn, but we're also here to be together and think about, what we do and the importance of it, how people look at us. Any thoughts about how she views her team, Joyce?
Well, she sounds like she has a fabulous, fabulous team, and her physician sounds fantastic. This whole idea of shared decision-making has come in the last few years, and I think it came out because things were not ideal. We're still in this transition of here's what I recommend and this is it, but this whole idea of there's so many decisions along the way in the metastatic setting, you've got to be on the same page. But I think her message to patients to advocate more for themselves, but also to physicians to this is the new world, this is what we all have to be really very supportive of, is an important one.
So, and I will say too that when you get back to your rooms or if you're home and getting ready to go to bed, you check your email and you will find a link to the entire interview that I did with her. It's only about a half an hour, but she has a lot more things to say. But one final thought, Erika, and again, this comes up so often, the impact of cancer diagnosis, breast cancer diagnosis on marriage.
It was hard on our marriage. I know he was stressed at different times, but trying to hold it together. He's been extremely supportive. I'm going to attribute it to chemo brain, but I had a shorter temper at times where I would snap over something or there would be something he would do that, okay, that might make me upset, but I just went to the extreme of being extremely upset over it. And so I think he was kind of a punching bag that I used, not physically, but just from an emotional perspective. So I think he really dealt with a lot during that time. My husband can drive me crazy on a good day. I've known him for over 15 years. But I do think I took more out on him. I would get angry more quickly with him about things. And so I think that was very hard to go through.
Erika?
Yeah, I can't imagine. I think she doesn't give herself enough credit. In that first video when she said, well, luckily I was home for 12 weeks right after I had my baby to rest. I didn't feel like I was resting for 12 weeks. Like, oh, I could sign up for chemo right now, right? But, obviously it's stressful, and I think it's stressful for the caregiver too. And we don't often talk about caregivers enough, but, he has this baby, this wife that's sick and getting chemo, and, he probably doesn't even want to talk about how stressed he is because he doesn't want to make her more stressed, right? And I think, there's less resources really for caregivers out there too.
Kevin?
Yeah, that's exactly what I was thinking about also. We have a very good friend who's an oncologist, and her sister has breast cancer. And we've had the conversation of, okay, well, there's the patient who's impacted, and then there's the circle, like the sphere around them of their advocates and loved ones. And then there's the sphere around them. And you think about all the people that can be impacted, like as coming together as a village to help treat somebody and care for somebody, but just all the ripple effects that can happen beyond just that one person.
Hope?
Yeah, I mean, I think we hear this a lot, and paying attention to it is another really important thing that we can do. Not only from, talking, like we have our psycho-oncology people and we have a better resource than we used to have. It really helps a lot for people to talk about it and sometimes for them to talk together. There are support groups for the partners, which I think can really help what people are going through. And then just our conversations, with people to say, this is as expected. And, we do tend to use antidepressants a fair bit also, which helps some with that irritability. I mean, she's a young woman who just had a kid. Her hormones were a mess. No wonder she, and, the chemo and besides also does that. So that plays a really big role. And so does the sharing of decisions, where the partner is also involved. I was telling one patient whose husband is always there with her that, we have patients that we see through the continuum of their disease, even when they're dying, and we've never met their partner. Mm-hmm. And, this is really tragic, I think. So having the person there who's sharing in the decisions with you and your providers and the entire team that's taking care of you makes a big difference.
So thank you so much to the faculty. Thank you for coming. Come on back tomorrow morning, 7:30. We're going to start out talking about lymphomas, a new first-line therapy for Hodgkin lymphoma. Hey, checkpoint inhibitors finally hit Hodgkin lymphoma. We're going to talk about that tomorrow and a lot more. Have a great night. Thanks so much.
Thank you.